First of all, thank you very much to the organizers and also to Partha. It's been a wonderful experience listening to everybody speak before me, and it's going to be very difficult for me to be a better orator than everyone else before me. So, I think I will start off with this paper that Dr. S.V. Madhu published from Delhi, which looks at the Young Diabetes Registry of ICMR. And if you look at the death rates, 11.6% of children have died in 6.4 years of diagnosis of type 1 diabetes in a tertiary care center in Delhi. It must have taken him a lot of guts to actually publish this. And most of those deaths are either because of dropouts or lack of insulin or infectious disease. Now, when I first embarked upon thinking of trying to do something in the government setup, I realized I can't go for a 780G pump. So I chose the yellow line, which is the intermediate level of care as described by Graham Ogle in his paper as part of the ISPAT guideline. So that talks about it has to be basal bolus insulin, 100 strips a month, point of care, looking at anthropometry, looking at all of the complications being screened, diabetes education, and if you're able to do that, you should be able to reach a goal of somewhere around 8 to 9.5. Ranveer was showing his data. That should reduce mortality. So that was my aim. And I think Dr. Varuna was talking about implementation research. This is essentially that. So we created a structured program wherein we would provide the medication, there would be monitoring, there would be counseling, emergency care, and from day one I realized what you've not published, you've not done. So creation of a web-based application portal for an electronic registry. Everything that we've done is on that registry, from supplies to stores, to tests, to clinical examinations, to investigations. And these are the components I'm not going to talk about in type 1 diabetes care. And you've got to think of a model which is scalable, again, echoing what Dr. Archana said, replicable, cost effective, and in line with the national NCD program. So we launched initially 5 district hospital type 1 diabetes care clinics. So the adult NCD clinic in the district hospital got converted to a type 1 diabetes clinic once a week. That's the logo of our type 1 diabetes clinic, which is once a week. And this is part of the training. This is what one of our clinic look like. And we realized there are 2 or 3 things that you need to do. Number one, first of all, let people know that you're doing it. So we published in Lancet and we published our methodology paper before anybody else could say that they had done it first. And Partha already showed this slide. So there are 27 health districts. By this year, we have implemented it in 15 districts. The next PIP, we've already written it up and it's ready. We'll go for the next 15 districts. So by end of next year, I'm hoping and praying all of West Bengal will be covered. And I'll just show you what we started off with these 5 district hospitals as a pilot. We compare the baseline results with the ones at the end of 2 years. We've purposefully left out analysis of data of the newly diagnosed ones. Why? Because obviously that will give you very good results and it will actually overinflate your achievements. So first thing, these were mostly kids who were getting treated elsewhere, particularly in tertiary care hospitals where adult endocrinologists were looking after them. So we've now moved them out into the districts where it's the MD medicine and the MD pediatrics who are looking after under the model with our guidance. Look at the family income per month. It's about 7,000 rupees for a family of around 4.5 to 5 individuals. So it's about 15 to 1600 rupees per person is the monthly income. And you can see what the age and other things are. I'm just going to highlight these. And not surprisingly, even in tertiary care hospitals, about 40% of them were on premixed insulin, something which we've discussed. At the end of 2 years, everybody's on basal bolus insulin. And if you look at insulin injection sites, we looked at a significant proportion, there were problems. After 2 years, almost all of them have healthy insulin injection sites. Look at the frequency of blood glucose monitoring. It's moved on to at least twice a day. We want it to be at least 4 times a day. And the proportion of people who are not self-injecting has improved. The ones below 7 years or 5 years, some of them do struggle, and that's the reason why it's not 100%. We've looked at everybody's physical and anthropometric examination because monitoring growth and development is important, which we have shown over a period of 2 years has dramatically improved. The glycemic control, so we started off with an A1C somewhere close to 10. Not surprising. And at the end of 2 years, we've brought it down to 8% for the entire cohort, which I think is extraordinary under the given circumstances for this kind of population that we're looking at. And if you're looking at all of the other parameters, I'll not bore you with all of them, just point out some of the more important ones. And if you look at ketoacidosis rates, in 2 years, our ketoacidosis is 0 now. Hospitalization, 0. Death, 0. What about psychological well-being? Something which we are all talking about but not documented. So we looked at quality of life and diabetes, health-related quality of life. Look at all of those parameters. They have improved dramatically in all of our patients. Also for the parents, because it's not the individual that you're treating, you are looking at the entire family. General well-being, quality of life outcomes, family functioning and social support. All of those parameters have improved. Now we are talking about costs, right? I told you that the average family income is somewhere around 7,000. So if you look at the cost at the bottom, at baseline, they were spending about 3,500 rupees for that one child. So 50% of the family income was going to treat that one child. That's come down to 416 rupees a month, which to you and me might not mean a lot. 3,000 rupees come home. But for that family, it's dramatically beneficial. I should stop there. Thank you very much.